A good day, everyone. My name is Remy Dulery. I work in Saint-Antoine Hospital in Paris. For the next minute, my goal will be to talk about the latest advances in the management of Hodgkin lymphoma. These are my disclosure. Decade after decade, the prognosis of Hodgkin lymphoma has improved with the advance of new treatment strategies. Hodgkin lymphoma is now a highly treatable malignancy with a high cure rate. In early stage disease, the 5-year overall survival ranges from 96 to 99.4%, and in advanced stage from 56 to 89%. However, this is the tip of the iceberg, if I may say. Depending on the selection of frontline therapy, approximately 10 to 15% of patients with early stage Hodgkin lymphoma and 15 to 30% of patients with advanced stage disease will have primary refractory lymphoma or experience a relapse. Despite the approval of novel therapies, autologous stem cell transplantation remains the standard of care in these patients. The data supporting the benefits of autologous transplants dates back to 2 small studies with patients treated in the 90s, reporting a 3-year event-free survival from 53 to 55%. What is, for me, a very important matter in all the presentation I will make and all the data I will show you is always to bear in mind that, yes, we need to struggle to improve the response rate, to improve overall survival, but every time we have to bear in mind that we have to consider also the quality of life of the patient. In this study, 459 and 56 Hodgkin disease survivors were treated in Norway, and they were compared to norms from 2,214 subjects in the general population. The Hodgkin lymphoma survivor had lower scores than the normal controls on all scales after adjustment for age, gender, and educational levels. Statistically significant differences were found in general health, physical functioning, role limitation, especially physical, social functioning, and in vitality. Patients with disease stage 1B to 2B had the lowest scores on all scales. In another study evaluating the health-related quality of life of 935 patients treated in the randomized H8 trial, data after treatment for early-stage Hodgkin lymphoma show that patients experienced strain and limitation in all subdomains apart from cognitive functioning. And also, patients have reduced motivation. Differences in health-related quality of life improvement with time were linked to age and sex. Fatigue status at the end of treatment seems to predict subsequent quality of life. Persistent fatigue represents one of the greatest challenges in Hodgkin disease, and efforts should be undertaken to identify contributing factors and describe better the patterns of recovery within the virus quality of life domains. Because patients with Hodgkin lymphoma are often young, the effects of treatment on quality of life can really jeopardize their return to normal life, which might have serious personal, familial, social, and professional consequences. As a doctor, I prefer to look at my role in the cure of the disease in a humble way. I mean, in Hodgkin lymphoma, we have many randomized controlled trials and international guidelines to help us decide the best treatments. Whether the patient is cured or not depends much more on the state of the art. What I can bring as a doctor to improve overall survival is, in a way, limited. I just need to prescribe the best available treatments and follow international guidelines. However, looking at the quality of life in all aspects of life, I believe I can play a very important role, and that my actions and the action of all the team I work with, all the person I will refer the patient to, all the time I will spend with the patient to listen to him, trying to improve all the symptoms. All my actions can help bringing a wide range of improvements. So what we do to improve quality of life? Well, I think emphasis on health-related quality of life following therapy may inform initial treatment decisions and long-term survivorship goals. We need to learn more about the impact of treatments on quality of life. Future research should include prospective longitudinal randomized designs across both treatments and time. We need to gain further insight into the course of recovery after cure, considering all aspects of life. A very important thing in this matter is that it is a teamwork. It's not just a one doctor alone or just a doctor and a patient. It's everybody, the family, and all the patients that are in care that should work together. So that's one way really to improve quality of life. The other way is to develop more effective and less toxic new therapies. And that's now what I will talk about. And I will start with frontline therapy in Hodgkin lymphoma. So you all know that the standard of care in Hodgkin lymphoma in early stage is AVD. Now we're trying more and more to do combination therapy with chemotherapy and immunotherapy. And this is now an interesting study presented at ASH 2019. In this study, patients over 18 years of age with newly diagnosed classical Hodgkin lymphoma, stage 1 to 4, were included. Patients were treated sequentially with 3 cycles of Pembrolizumab at 200 milligrams every 3 weeks, followed by an interim PET-CT for primary analysis. Subsequently, patients received 4 to 6 cycles of AVD chemotherapy based on initial stage. 3 cycles of Pembrolizumab was highly active in patients with newly diagnosed early and favorable or advanced stage Hodgkin lymphoma. Pembrolizumab monotherapy resulted in over 90% reduction of tumor metabolic volume in the majority of patients, and when followed by 2 cycles of AVD, it resulted in a complete remission rate of 100%. No patient have experienced progression or change of therapy to date when it was presented at ASH, and treatment was overall very well tolerated. So this radiotherapy and bleomycin-free approach warrants further investigation in larger trials to confirm response rates and assess efficacy compared with other novel combinations in the frontline setting. combination of anti-PD-1 and AVD was also evaluated in the NIVAHL phase 2 trial, which enrolled treatment-naive early-stage and favorable classical Hodgkin patients between 18 and 60 years in 35 German centers. In Arm A, patient received 240 milligrams of Nivolumab and AVD on day 1 and 15 of each 28-day cycle for a total of 4 cycles. In Arm B, it was the sequential arm, the same treatment was administered sequentially, starting with 4 cycles of Nivolumab in 2 weekly intervals, and followed by 2 times Nivo AVD and 2 times AVD. Both groups received 30 gray of involved sites radiotherapy. Serious adverse events occurred in 38% and 28% of patients in group A and B respectively. Treatment-related morbidity was defined as organ toxicity above grade 3 or anemia, thrombocytopenia, or infection at grade 4. And it was documented in 16% and 20% of patients respectively. At the first interim resection after 2 cycles of Nivo AVD or 4 cycles of Nivolumab, the overall response rate was 100% and 96% respectively. After completion of systemic therapy, the overall response rate was 100% and 98% respectively, with a complete remission rate of 81% and 86% respectively. The 1-year progression-free survival was 98% and the 1-year overall survival 100%. So overall, concomitant and sequential therapy with Nivolumab and AVD seems feasible with acceptable toxicity. The response rates are high. Of course, we need longer follow-ups, larger number of patients, and as I said before, this needs to be compared to strategy with other immunotherapy or other combination therapy. Another interesting approach was presented last year at ASH for elderly patients. So this study was a phase 2 study including 89 patients with stage B to 4, and patients' median age was 68 years, ranging from 61 to 88. The idea that in elderly patients, the treatments are limited by the toxicity. So the author developed a new combination therapy with prednisone, vinblastine, doxorubicin, and bendamustine. It was administered every 3 weeks and up to 6 cycles. The complete metabolic response rate was 77%. The 2 years overall survival, 84%. The 2-year progression-free survival, 61%. In terms of toxicity, 21% of the patients had serious events as infection, 12% had hematologic toxicity, and 4% cardiac toxicity. According to the long-term follow-up data from the German Hodgkin study group HD14 trial presented at ASH 2019, for patients with early and favorable Hodgkin lymphoma, disease control may also be improved with a dose intensity regimen of 2 cycles of escalated B-cup followed by 2 cycles of ABVD. This strategy was compared to AVD alone. The trial enrolled a total of 1,550 patients, but only 1,112 patients were available for survival analysis and were presented at HASH. Patients were randomly assigned to receive 4 cycles of BVD or 2 cycles of BCOP, followed by 2 cycles of BVD. All patients also received 30 gray of involved radiotherapy. At a median follow-up of 97 months, patients on dose intensity arm had significantly fewer lymphoma relapse and improved 10-year progression-free survival compared with patients on the 4 cycle of ABVD arm. The PFS was 91% compared to 86%. Now, about salvage therapy in patients with relapse of refractory Hodgkin lymphoma, there have been recently it's interesting data on combination therapy with traditional chemotherapy combined with immunotherapy. First, I would like to present the results of Brentuximab Bendamustine added to ICE, which can allow for high rates of disease control. In a phase 1-2 trial, patients received 2 cycles of Brentuximab ICE before evaluation, and only chemotherapy, and only patients in complete response received the 3rd course. Then an injection of Brentuximab alone was administered before autologous transplant if patients were in response. If patients did not respond, the study stopped after 2 cycles of Brentuximab ICE, and patient had another treatment. Among the 39 patients, 3 had progressive disease during the treatment phase. 20 patients out of the 25 with complete metabolic response underwent autologous transplant. 13 patients relapsed during the follow-up, and no death was observed without progression. The progression-free survival was not reached. The median progression-free survival was not reached, and the 1-year progression-free survival was 69%. The 1-year overall survival was 100%. Another promising combination is anti-PD-1 with ICE. In this study, Nivolumab was used. It's a prospective multi-center trial. Patients had relapsed or refractory Hodgkin lymphoma and were treated as a 2nd-line therapy. They received 3 milligrams per kilo of Nivolumab every 2 weeks for up to 6 cycles. PET-CT was performed after 3 cycles and 6 cycles. Then, after 6 cycles, patients in complete remission proceeded to autologous transplant, while patients not in complete remission received NICE, which is Nivolumab ICE, for 2 cycles. And the results are good, as you can see. Well, it's preliminary data, but at 1 year, the overall survival was 97%, and the progression-free survival 79%. Now, what if salvage therapy could be chemo-free? In this phase 1-2 study, Brentuximab Bendamustine and Nivolumab administered in combination were evaluated as initial third-line therapy in patients with relapsed refractory Hodgkin lymphoma. Patients received up to 4 cycles of combination treatment with Brentuximab administered on day 1 and Nivolumab on day 8 of the first cycle. For cycles 2 to 4, Brentuximab and Nivolumab were both administered on day 1. Patient could proceed to autologous stem cell transplantation. 62 patients were enrolled, and the complete response rate among all treated patients was 61%, with an objective response rate of 82%. Before autologous transplants, adverse events occurred in 98% of patients, but it was mostly grades 1 and 2. With a longer follow-up, you can see that the overall objective response rate was 85% and the complete response rate 67%. And better responses were observed in patients with high expression of CD30 plus cells. The patient-free of progression or death was 91% after autologous transplants and 78% in all treated patients at 2 years. So it's an interesting combination with mild toxicity, and this combination is also feasible in patients older than 60 years. This is a small study in which 19 patients were included. The objective response rate was 95%. Complete response rate was 68%. 14% of the patients experienced grade 3 peripheral neuropathy and 16% immune-related grade 3 adverse events. Well, another I think I like to use it in patients, especially if they are fragile, is the combination of Brentuximab combined with Bendamustine as first cellular therapy. It's also highly active with a manageable toxicity profile. This phase 1/2 study enrolled 53 patients. Patient received a total dose of 1.8 milligram per kilo of Brentuximab Bendamustine on day 1 and 90 milligram per square meter of Bendamustine on days 1 and 2 of a 21-day cycle for up to 6 cycles. Patient could undergo autologous transplants anytime after cycle 2. Following autologous transplant or completion of combination therapy, if not proceeding to autologous transplant, patient could receive Brentuximab monotherapy for up to 16 cycles of total therapy. And after a median of 2 cycles, the objective response rate was 92.5%, with 74% of the patients achieving complete remission. 40 patients underwent autologous transplant, and 31 patients received Brentuximab Bendamustine monotherapy. After a median of 21 months of follow-up, the estimated 2-year progression-free survival was 67% and 63% for patients who received autologous transplants and all patients respectively. Now, unfortunately, despite these advances in combination therapy, some patients were in relapse. And at the third-line therapy, I think we should refer most of the patients, if they are eligible and fit, to allogeneic stem cell transplantation. Allogeneic transplantation, following a non-myeloablative or reduced intensity conditioning, is considered a valid approach to treat patients with refractory Hodgkin lymphoma if they relapsed after autologous transplants. In this retrospective study, we compared the outcome of patients with Hodgkin lymphoma undergoing reduced intensity conditioning or non-myeloablative conditioning from Haplo, unrelated or cord blood donor. 98 patients were included. The median follow-up was 31 months for all cohorts. In Haplo group, the overall survival was 75% and the progression-free survival 66%. The cumulative incidence of grade 3-4 GVHD was 3%, and the cumulative incidence of chronic GVHD was 15%. It was significantly lower compared to other type of donors. The non-relapse mortality was 12%. After adjustments for significant covariates, unrelated donor and cord blood were associated with significantly lower GVHD-free relapse-free survival, with a hazard ratio of 2.02 and 2.43 respectively, compared with Haplo donors. The question of the best donor type between Haplo identical in the era of post-transplant cyclophosphamide and match-related donor is still debated. Thus, we performed a multi-center retrospective study and analyzed the data of 151 consecutive Hodgkin lymphoma patients who underwent non-myeloablative or reduced intensity conditioning allotransplant. In the Haplo group, the overall survival was 81%, the relapse incidence 21%, and the non-relapse mortality was 9%. There was no significant difference with match-related donor. In multivariable analysis, match-related donors were independently associated with lower GVHD-free relapse-free survival compared to Haplo donors with hazard ratio close to 3. Disease status at transplant and other than complete response was also associated with lower GRFS in multivariable analysis. The good results of Haplo with post-transplant cyclophosphamide were also confirmed in this large UBMT study. In the Haplo group, overall survival was 72%, progression-free survival 57%, and no significant difference could be observed in other subtypes of lymphoma. Now, a very debated question is, can we use immunotherapies as a bridge to allogeneic transplants in primary refractory or relapsed Hodgkin lymphoma? First, I would like to show this real-life data showing that the results of Brentuximab Bendamustine as a monotherapy in relapsed refractory Hodgkin lymphoma. As you can see here, the blue line is patient who didn't go to transplant. The red line is patients who underwent transplant, and there is a significant difference. The progression-free survival was the median survival was 18.8 months in the transplant groups compared to a median PFS of 8.7 months in the no transplant group. So this study shows in real life that transplants should be proposed to those patients. As a matter of fact, this is data with monotherapy with Brentuximab, and it was recently presented in the virtual EHA a comparison of Brentuximab to Pembrolizumab, showing that Pembrolizumab might allow for better outcomes than Brentuximab monotherapy. So that's why more and more I believe that we're going to use Brentuximab early, and not in monotherapy, but more in combination therapy. And using anti-PD-1 before allogeneic transplant was assessed with extended follow-up in a large international cohort. The results argue that allogeneic transplant performed after PD-1 antibodies is feasible strategy associated with an excellent progression-free survival of 65% and a very low cumulative incidence of relapse of 21% for this disease at this stage. Thus, the use of post-transplant cyclophosphamide in this study appears to be associated with improved outcomes and may represent the optimal transplant strategy in this population. All patients who underwent allogeneic transplant remain disease-free in this study, whereas 62% of patients with subsequent allogeneic transplantations had relapse. So it means that most patients with relapse or refractory Hodgkin lymphoma treated with anti-PD-1 monotherapy eventually progressed, notably those who did not achieve complete remission. Patients undergoing consolidation with allogeneic transplantation after anti-PD-1 therapy experience prolonged disease survival compared with non-transplant patients, but this difference did not translate into benefits in overall survival. This information should be considered when evaluating the risk-benefit ratio of allogeneic transplant after anti-PD-1. Now, in this report recently presented on 59 Hodgkin lymphoma patient undergoing Haplo stem cell transplantation with post-transplant cyclophosphamide as GVHD prophylaxis. This study compared the outcomes based on pre-transplant exposure to checkpoint inhibitors. So what is interesting that checkpoint inhibition before Haplo seems to improve progression-free survival in patients receiving Haplo with PTCI as GVHD prophylaxis. Program PD-1 blockade as bridge to Haplo with PTCIs does not increase in the study toxicities and NRM. So to understand why post-transplant cyclophosphamide does improve outcomes, a recent study was conducted in 18 patients. It showed that Nivolumab persists in plasma after transplantation up to 56 days after transplant. Nivolumab binds to allogeneic T cells and generates an increased T cell activation. Nivolumab exposed patients had a higher incidence of severe acute GVHD and a more effective T cell profile compared with anti-PD-1 naive patients. However, patients receiving post-transplant cyclophosphamide-based prophylaxis showed a similar risk of acute GVHD and T cell profile irrespective of the previous Nivolumab exposure. This T cell activation status can be mitigated with the use of post-transplant cyclophosphamide, thus reducing the risk of acute GVHD. So to conclude on this part of the use of anti-PD-1 before allogeneic transplantation, I would like to state that first, allogeneic transplant after anti-PD-1 is a feasible strategy associated with an excellent progression-free survival and a low relapse for this disease. Patients undergoing allogeneic transplant after anti-PD-1 therapy experience prolonged disease-free survival compared with non-transplanted patients. The use of PTCI appears to be associated with improved outcomes and a reduced risk GVHD. For patients with Hodgkin lymphoma, the use of anti-PD-1 cell progression seems to be suboptimal when a curative option can be considered. Thus, a consolidative strategy with allogeneic transplant should be discussed for all responding patients. Now, can you use immunotherapies for relapse after allogeneic transplants? Well, there are mainly two studies which assessed the use of anti-PD-1 after allogeneic transplants. The first was published by Charles Herbeau in Blood in 2017. It included 20 patients who relapsed after allogeneic transplants. GVHD occurred in 30% of the patients. Interestingly, all patients had a prior history of acute GVHD. And Nivolumab allowed for a very high response rate with an objective response rate of 95%, included 42% in complete remission. Compared with standard option for this indication, anti-PD-1 blockade with Nivolumab provided durable disease control after allogeneic transplant. The overall survival was 79% and the PFS 58%, and it had an acceptable safety profile. Another study evaluated the use of anti-PD-1 in case of relapse. 30 patients were included. Any type of GVHD occurred in 17 patients, including 10 patients with acute GVHD. The cumulative incidence of grade 3 for acute GVHD was up to 20%, and the cumulative incidence of severe chronic GVHD was up to 17%. A total of 4 patients had a partial response to the treatment for a chronic GVHD. It meant that GVHD occurred early after initiation of anti-PD-1 with an onset after a median of 2 doses. Opposite to the previous study I presented, 5 patients had no history of GVHD prior to anti-PD-1. But in line with the previous study, anti-PD-1 allowed for very high response rate. The objective response rate was 77%, including 50% of complete response. And at last follow-up, 68% of patients were alive, 26% of the patients died related to GVHD. So to conclude on the use of anti-PD-1 after transplantation, allogeneic transplantation in case of relapse, I will say that PD-1 blockade can provide durable disease control, so it works. You can use it. It allows for prolonged survival in patients relapsing after allogeneic transplant. However, PD-1 blockade may include GVHD, may induce GVHD in 30 to 55% of patients, which is very high, and it seems especially at higher risk in patients of prior history of GVHD. So what I personally do, how I treat relapse after allogeneic transplants, well, first I will try, if possible, a Brentuximab, either alone or in combination with Bendamustine and donor lymphocyte infusion. It will depend, of course, of the history of the patient, of the type of response, but it will be my first option. And in case it fails, in case, you know, the way I have no other options, I will use anti-PD-1 because it allows for good disease control. And if I don't do that, unfortunately, there are not many other options to control the disease and allow for survival. One other option was recently presented by Badar et al. In the British Journal, is the use of ibrutinib. It was used in 7 patients, and in most patients it allowed for complete response. So I would say if your patient had a history of GVHD, you know that anti-PD-1 might be at high risk of inducing another GVHD. So maybe an interesting option will be ibrutinib in that case. Personally never tried, but I think it should be considered. So to conclude my talk, here are a few take-home messages. My first, and I think maybe most important message is that quality of life is impaired after the treatment. It's not just a treatment that you do for 4 months or 6 months and then the patient is cured, he can move on as if nothing happens. Of course, it has a psychology impact, but what studies show that patients experience strain and limitation in most aspects of life. And we need to gain further insight into the course of recovery after cure, considering all aspects of life. It's also very important, I think, to include in future trials prospective, longitudinal randomized designs across both treatments and time. Now, in frontline, recent data show that we should use more than ever PET-guided therapy. If you have, after 2 cycles of ABVD positive PET, recent data show that it works if you escalate to BCOP. On the opposite, if you started with BCOP and after 2 cycles the PET is negative, it works if you use a BVD, and it's better than using 4 cycles of a BVD without starting with BCOP. What are the future perspectives? I'll show you, I think, very interesting data of the combination of anti-PD-1 and AVD in elderly patients more than 60 years. I think one can use the combination of prednisone, vincristine, doxorubicin, and bendamustine, or the combination of brentuximab and AVD. Of course, we need a randomized control trial to compare the new combination therapy and evaluate which one is the best. In second line, if the patient relapse or if he's in a primary refractory disease, the latest advances show that you can safely use combination of immunotherapies and in case of response, perform autologous transplants. I've shown you interesting results of Brentuximab ICE with a PFS of 69%, Nivolumab ICE, PFS of 79%, Brentuximab Nivolumab, sort of chemo-free combinations with a PFS of 91% after transplant, and Brentuximab Bendamustine with a PFS of 75%. Finally, if the patient relapse, first, if you believe is at high risk of relapsing, there are strong data, this I couldn't show you, but I've shown you in the use of combination that maintenance with brentuximab works, and it should be given to patients with a higher risk of relapse, regardless of the remission status or prior brentuximab exposure prior to autologous transplants. In case of relapse after autologous transplants, allogeneic transplants performed after anti-PD-1 is feasible strategy associated with an excellent PFS and a low cumulative incidence of relapse. If you have to choose maybe one GVHD prophylaxis strategy, I would recommend the use of post-transplant cyclophosphamide. When other therapeutic options failed, anti-PD-1 can be used cautiously in patients relapsing after allogeneic transplants with a good objective response rate, but you must bear in mind that it may enhance the risk of GVHD. Finally, I didn't talk about CAR T-cell because there are no data in clinical use in patients, but hopefully I will be happy to read maybe in the next ASH or next Congress that CAR T-cell works in these patients, and hopefully it will be a new solution with an acceptable quality of life. Well, I would like to thank all my colleagues in the hematology departments in INSERM. I would like to thank the nursing staff and also the LISA and the SFGM-TC. And finally, I thank you all for your attention. And if you have any questions, feel free to contact me with my email or on Twitter. Thank you.